Welcome back, everyone. So now I'm going to talk about myeloid neoplasms. This should be the last part of the white blood cell pathology. So myeloid neoplasms are divided into three broad groups: acute myeloid leukemias, myelodysplastic syndromes, and chronic myeloproliferative disorders. So I mentioned about this already, but I would like to talk again because it is important for you to understand the big picture of the myelodysplasms. For acute leukemia, the main pathogenesis is the maturation arrest. So there is accumulation of immature cells within the bone marrow. So we expect to see so many blastic cells within the bone marrow accumulated within the bone marrow, and the blast cells may exit the bone marrow and enter blood circulation. So we will see a lot of blast cells in the peripheral blood as well. For myelodysplastic syndrome, we will see the abnormal maturation. We will see dysplasia. We will see abnormal growth of the hematopoietic cells. So you will see abnormal cells, ugly cells within the bone marrow. But most of the myelodysplastic syndromes will have the cytopenic blood picture because the abnormal cells cannot exit the bone marrow. So they will be accumulated in the bone marrow and they cannot be released into the peripheral blood. So you see cytopenias in these patients. And the third group is chronic myeloproliferative disorders. There is increased production of one or more terminally differentiated myeloid elements, meaning that there is increased proliferation, neoplastic increased proliferation of the hematopoietic cells of the myeloid cells, but the differentiation is quite normal. So we will see not so many blood cells. We will see maturing different stages of myeloid elements. If the predominant element is erythroid cells, that is polycythemia vera. If the main component is megakaryocytes, the disease may be myelofibrosis or essential thrombocytosis or thrombocythemia. If the predominant element is myeloid cells, the disease is chronic myeloid leukemia. This is just big picture for you to understand. And this slide will show how they are distinguished from each other. Chronic myeloproliferative neoplasms, myelodysplastic syndrome, and acute myeloid leukemia. All of these are clonal disorders. All of these are malignant, are considered malignant. So for myeloproliferative neoplasms, there is increased mature appearing cells, less prominent clinical cause than acute myeloid leukemia in many instances. That's why the conditions are called chronic myeloproliferative neoplasms. And there is valuable risk of transformation into acute myeloid leukemia. For myelodysplastic syndrome, there are decreased circulating peripheral blood cells. There is abnormal differentiation of blood cells in the marrow. The clinical cause is less prominent than AML, and there is variable risk of transformation to AML, into acute myeloid leukemia. For acute myeloid leukemia, there are decreased circulating mature peripheral blood cells, but there is presence of immature cells in marrow and or peripheral blood. So the white count may be high because of the presence of abnormal cells, blast cells within the peripheral blood. And the clinical cause is fulminant, but highly responsive to chemotherapy. So the most malignant group, acute myeloid leukemias. So acute myeloid leukemias are associated with acquired oncogenic mutations that impede differentiation, leading to the accumulation of immature myeloid blasts. Most genetic changes interfere with transcription factors required for normal myeloid cell differentiation. One genetic change that I would like to highlight, it is very important. It is a must know, is translocation 1517, resulting in RARA PML fusion. RARA PML fusion. So this one, this fusion protein results in abnormal retinoic acid receptor interact with transcription repressor, so resulting in maturation arrest and uh, resulting in accumulation of promyelocytes. But as we see, it is associated with RARA, retinoic acid receptor, right? And this fusion protein can be overcome by administration of vitamin A. Just give the patients vitamin A and the cells will differentiate into more matured stages. The administration of vitamin A can overcome this fusion protein. So we just order vitamin A in the form of all-trans retinoic acid extra. Is interesting, is amazing, isn't it? The treatment is just to give vitamin A. It is pathogenic significance and therapy guiding. And according to FAB classification, so acute AML may be classified according to cell type and degree of differentiation. And if there is no differentiation at all, that is M0, minimal maturation M1 with maturation M2, and acute promyelocytic leukemia M3, which is associated with translocation of chromosomes 15, 17, which results in RARA, RAR alpha PML fusion protein production, right? Which can be treated by vitamin A or trans-retinoic acid. And this one is also special because of its tendency to cause disseminated intravascular coagulation or DIC, because the tumor cells contain a lot of granules, and these granules, when released, may activate coagulation, resulting in consumptive coagulopathy or disseminated intravascular coagulation. M4, if there is myelomonocytic differentiation, M5 monocytic differentiation, these two types are associated with tissue infiltration of the tumor cells. They are associated with gum hypertrophy. This one is also amazing features. And with if there is erythroid differentiation, that is M6, and megakaryotic differentiation, that is M7. But the new classification will group AML with specific genetic aberrations into group 1, AML with genetic aberrations, including A21, and this one, M3, is also included here as well. Just get the general principle of these. Don't have to memorize everything because too much for you. So the new classifications, WHO classifications, will divide AML into with genetic aberrations, with MDS-like features, therapy related, and not otherwise specified. So diagnosis of AML requires the detection of blasts within the bone marrow more than 70% of cellularity, of myelocellularity, and myeloblasts need to be distinguished from uh, lymphoblasts. Myeloblasts have a fine chromatin with 2 to 4 nucleoli, and the one feature that distinguishes myeloblasts from lymphoblasts is the presence of acylophilic peroxidase positive granules, or our rod in the cytoplasm. This one, and if there are plenty of our rods, this is promyelocytes. So this one should be APML or M3, promyelocytic leukemia. And for monoblasts, the cells are folded or multilobated nuclei with no our rod and non-specific SRS positive. And sometimes the patients present with only leukopenia without presence of blasts in the peripheral blood. That is a leukemic leukemia. So the peak age is around 60 years old, and patients will present with pancytopenia and APML or M3, acute promyelocytic leukemia. The release of the granules result in activation of the coagulation system, resulting in DIC or disseminated intravascular coagulation or coagulopathy. And AML with monocytic differentiation is quite unique in its capability to infiltrate into the tissue. So the patients may present with gingival hypertrophy or skin infiltration. CNS involvement is less common than ALL, and localized mass is rare. But if there is a mass caused by accumulation of myeloblasts, that is myeloblastoma or chloroma. So the prognosis is quite variable, but for M3 it is quite unique with T15, 17 translocation. 80% of the patients can be cured with ATRA or all-trans retinoic acid and arsenic salts treatment. And the second group of the myelodysplasms is myelodysplastic syndromes. So myelodysplastic syndromes are clonal stem cell disorders characterized by maturation defects, not arrest. It is maturation defects. It is dysplasia. It is abnormal growth associated with ineffective hematopoiesis and a risk of transformation into acute myeloid leukemia. Pathogenesis is largely unknown, and marrow is often hypercellular. The cells are ugly, the cells are abnormal, but they are not released into the peripheral blood. So the patients usually present with pancytopenia. So clinical features in adults, 50% are asymptomatic, and the main presentation is pancytopenia. Yeah, I think it is too difficult for you to make the diagnosis. So, but we will see abnormal, sometimes cute, but abnormal cells like this. So just for for fun, don't have to worry much about making the diagnosis of MDS. And the last group, chronic myeloproliferative disorders, the last group of myeloneoplasms. So the chronic myeloproliferative disorders are associated with mutated constitutively active tyrosine kinases that circumvent normal proliferative control pathways. So the mutations result in growth factor independent proliferation and survival of marrow progenitors. And common clinical features include increased proliferative drive in the marrow, and there is sometimes homing of hematopoietic stem cells to non-marrow sites, resulting in a mass outside the bone marrow with hematopoiesis that are called that is called extramedullary hematopoiesis. And there is valuable transformation into a spent phase, meaning that early in the course the cells proliferate a lot, but in the end there may be a decrease in cellularity, and the clinical picture may turn into peripheral cytopenia in the end. It is a possible outcome of these disorders, and sometimes these disorders may be transformed into acute leukemia. So there are many types of chronic myeloproliferative disorders. I think you need to know all of them, but I believe that you have learned about these already in other lectures. Uh, uh, so the diseases examples include systemic mastocytosis, polycythemia vera, essential thrombocythemia, chronic eosinophilic leukemia, chronic myeloid leukemia, chronic myelomonocytic leukemia, primary myelofibrosis. And chronic myelogenous or chronic myeloid leukemia is the neoplasm of pluripotent hematopoietic stem cells, leading to preferential proliferation of granulocytic progenitors. It is distinguished from other myeloproliferative disorders by the presence of a chimeric constitutively active BCR-ABL tyrosine kinase. The pathogenesis of this type of myeloid neoplasm is unique. It is a translocation of chromosome 9, which is the location for ABL, and 22, which is the location for BCR. There is a breakage here and translocation. The translocation results in production of BCR-ABL fusion protein, and this protein has constitutively active tyrosine kinase activity. So tyrosine kinases generally activate cellular proliferation. So when there is production of this abnormal chimeric protein, the cells will proliferate all the time. But the differentiation is normal. So the cells differentiate, the cells proliferate and then differentiate into mature granulocytes. So in the bone marrow, we usually observe high cellularity composed of developing granulocytes. In the peripheral blood, we should observe leukocytosis composed of neutrophils, myelocytes, and myeloblasts must be less than 10%, must not be so high, because if myeloblasts is too high, that is acute leukemia. And basophilia is also a characteristic feature because this condition is not seen, is seen in only few conditions, and chronic myelogenous leukemia or chronic myeloproliferative disorders are amongst only few causes of basophilia. Thrombocytosis is also possible. Extramedullary hematopoiesis may result, and so we may observe splenomegaly as well, because the spleen is filled with hematopoietic cells. And this condition is seen in adults, particularly 50 to 60 years old. And clinical features include anemia and hypermetabolism. The treatment includes bone marrow transplant, and this one is important, imatinib. It is the imatinib is the monoclonal antibody against BCR-ABL kinase. It is targeted therapy. It is very important. And there are different phases of CML. Chronic phase may be asymptomatic if treated, and accelerated, so the blasts are increased. And then blastic phase, because so CML may be transformed into AML in the end. Other myeloproliferative disorders include polycythemia vera. So the clinical picture is erythrocytosis, basophilia, and platelet dysfunction. And 20% will develop spent phase and extramedullary hematopoiesis. ET, or essential thrombocytosis, or essential thrombocythemia. The clinical picture may be either bleeding because the platelets produced do not work very well, or the patients may suffer thrombosis. It is not quite aggressive, but the complications from bleeding and thrombosis may be fatal. And primary myelofibrosis, there is fibrosis in the bone marrow, so there is large extramedullary hematopoiesis. So the clinical picture is anemia with severe splenomegaly. And the last group of white blood cell neoplasms is the Langerhans cell histiocytosis. So it is a tumor of dendritic cells, immature dendritic cell. It is associated with BRAF mutation and immunophenotype. CD1A is quite unique for this type of cell. This for Langerhans cell, and here we see the Langerhans cells accumulate within the region, forming a mass. And for electron microscopy, we will detect Burbeck granule, look like tennis racket, like this Burbeck granule, which is characteristic for dendritic cells, for Langerhans cell. And there are different clinical syndromes, including multifocal, multisystem Langerhans cell histiocytosis. The specific name is Leteller CV disease, and the conditions may be present as unifocal and multifocal unisystem Langerhans cell histiocytosis or eosinophilic granuloma. And the lesion may be localized within the lung. It is called pulmonary Langerhans cell histiocytosis. Happy ending, right? You must be very happy that it is ended now. So, but it is not really the end. Just follow my lectures. There is another section on diseases of the thymus and the spleen. Okay. Thank you for your attention.